Welcome, everybody. This is a webinar on behalf of the World Federation of Neurosurgical Society's Young Neurosurgeon Forum. This is the first in our upcoming series of landmark papers in neurosurgery. Today, we're talking with Professor Jamie Cooper about his paper, Decompressive Craniectomy in Diffuse Traumatic Brain Injury, or the DECRA trial. Dr. Cooper is a professor of intensive care medicine at Monash University and an ICU physician at Alfred Hospital in Melbourne, Australia. For more than 20 years, he has led large randomized trials in traumatic brain injury and intensive care, leading to 16 papers in the NEJM and JAMA. He has 390 publications, over than 32,000 citations, and an H-index of 81, and more than $70 million in competitive research grants. We are really excited to have Dr. Cooper with us tonight, and we're going to let him talk about the DECRA trial. And then after he's finished sharing his slides, we will take some questions through the chat.
Okay, thank you, Megan. You can hear me okay now?
Yes.
Yep. Yeah, hi. So I'm Jamie Cooper. I've been working in Australia's largest trauma and neurotrauma centre at the Alfred Hospital for 30 years now, and during that time, both as a clinician and as a clinical trialist, I've been working collaboratively with neurosurgeons and others to try and improve outcomes from patients with severe TBI. Now, of the research programs that we've completed, the best known is the DECRA trial, and I'm going to talk to you about that today. Patient outcomes after early decompressive craniectomy for severe diffuse traumatic brain injury. Oh, interesting, this happened last time. The main thing about conflicts of interest is that there are none that are of importance to the DECRA trial. The trial was funded only by competitive grants from our national federal funding agency, the NHMRC, Australian Government, some state agencies, and intensive care foundations. The industry wasn't involved at all. So DECRA was published 10 years ago now. It has stood the test of time, but first I'd like to take you through the clinical context back in 2000 to 2002 when we were writing the grants to get funding for the trial. It was clear from many observational studies that severe traumatic brain injury had only 50% favourable, so 50% unfavourable outcomes where patients were severely disabled and or dead. It was a global public health problem, and we were, as we are now, desperately keen to try and improve that situation. We also felt, as clinicians and scientists, that if we could, that if intracranial pressure remained refractory for long periods of time, then that likely increased secondary brain injury and made outcomes worse. So the corollary being that if we could control it better and earlier, we might be able to improve outcomes. Better control should improve patient outcomes based on all the things we were using to manage severe TBI patients in the ICU. Also at that time and a little bit before that, decompressive craniectomy seemed to be increasing in use. It was being talked about a lot of meetings. It was being discussed and used more in some centres than others. But the reasons being is that it seemed pretty clear that craniectomy was good at reducing intracranial pressure. And it also seemed that sedating drugs could be turned off more readily and patients moved more quickly out or reduce their ICU times. That was discussed a lot. And so it seemed to us that of all the options that we did have available to test and find out whether they were truly good or not, craniectomy seemed to be the best bet for improving patient outcomes on many fronts. And that was the reason why we went to all this trouble to fund and then to run over a long period of time the DECRA trial. But we knew that to be sure of these things, to be sure that it was really a worthwhile approach, the only way to be sure was a high-quality randomised trial with concurrent control patients. And that kind of trial design was really missing in the traumatic brain injury space. We also thought that if DECRA really did control, if craniectomy really did control pressure better, it might be a really good way to explore and clarify further the efficacy of pressure reduction on brain injury and later patient outcomes. So we thought that would be a pretty major side benefit likely of the trial. So just running quickly through what decompressive craniectomy is. It's a neurosurgical procedure where skull bone is removed to decompress a swollen brain. The dura is usually, but not always, open, and the craniectomy procedure buys into a second procedure later on to cranioplasty to replace either the bone that's been taken out or a prosthesis, but sometimes much later when the swelling and other complications have fully resolved. The overall goal, of course, is to prevent death and disability. Decompressive craniectomy first described over 100 years ago. The current technique tested in DECRA first reported 50 years ago for the bifrontal craniectomy and duroplasty. But there are many variations, some popular with some surgeons, others not. But all of them are effective. The most important thing, all of them were effective to reduce intracranial pressure, we thought. The overall concept is probably 500 years old. Let the pressure down and the patient with raised pressure is likely to do better. The next thing to consider before looking at the paper in detail is the important things about timing of craniectomy after a severe TBI. Primary decompressive craniectomy is when there's a mass lesion evacuation to save a life and the bone is left out. The DECRA trial wasn't about that. Those patients were not included. Secondary TBI then can be at a number of different time points through the course of the patient's care. Sometimes when patients arrive in the emergency department, they already have critical brain pressure elevations with signs of coning, either clinical and on CT. It's then used often as a rescue procedure. Those patients weren't involved in DECRA. They couldn't be. It was an impossible situation to randomise and continue, and wasn't studied in the trial. Then once a patient reaches the ICU and their intracranial pressure has become refractory to standard therapies, usually with an ICP monitor. Certainly in DECRA it was with an ICP monitor, but the procedure is sometimes done without. It can then be done at different time points. It can be done as soon as the ICP becomes refractory to first and second tier therapies, and that's the point where patients were randomised in DECRA. We did that deliberately because we felt that if refractory ICP was maintained for longer periods of time, that was likely to be the time when secondary brain injury was taking place. And we designed the trial to try and minimise that element and maximise the chance of benefit. It can also be done later, after many hours or days of refractory ICP. And finally, it can be done as a rescue procedure after all other options, including barbiturate coma, for example, have failed to save a life. Now, other things to note are that the use of decompressive craniectomy in severe TBI assumes a number of important things for it to be valuable. It assumes that the CT scans have been done and made a diagnosis, and that it's clear the type of injury that the surgeon is treating. Secondly, it assumes there's good quality intensive care with ventilator management for often several weeks, with the nursing care and the capability to avoid complications of long-term coma care in ICU. And those things are not available in all places around the world. It also assumes safe transports to operating theatres for patients who are unstable with high intracranial pressure, and that ICP is routinely measured and is increased and is refractory to those conventional therapies. It is better, we think, if an EVD drain has been used for CSF drainage and to maximise other non-surgical means of controlling ICP, but not everybody uses them, and parenchymal catheters are widely used as well. The first and second tier therapies that have failed include sedation, seizure control, positioning, hypertonics, CO2 control, basically all the therapies that are used by intensivists in ICU prior to barbiturate coma. So in 2021, what are the last tier therapies that are available? There's really only two, and neither are ideal. So barbiturate coma is not ideal. It buys patients into longer periods of stay in intensive care, but it does require fewer transports to operating rooms and CTs, or decompressive craniectomy, which does require transports to unstable patients, and like all surgery, does have surgical complications. The third option in 2002, when we wrote the grants, was hypothermia. Now, we felt at the time that hypothermia wasn't included in the DECRA trial protocols, and we did that deliberately because we felt the risk-benefit was against hypothermia, and that it was likely to complicate assessment of the true findings after our trial was finished. So we didn't include in the protocol, and when Urotherm was published quite a lot later in 2015, it became clear that we were right, because hypothermia as used in that trial increased poor outcomes and increased mortality. And although there is still variation, as there is in many aspects of neurotrauma, is now used far more infrequently worldwide. So the last two options for once stage 1 and 2 therapies have been used are the same today as they were in 2002. So here we have the DECRA trial paper published in the New England Journal, our highest impact medical journal. It was completed by a collaboration of specialists, intensivists and neurosurgeons. Two of Australia's highest, most eminent neurosurgeons were involved in this trial. There are 15 sites across 3 countries, Australia, New Zealand and Saudi Arabia. And all of the clinicians from all the collaborating specialties agreed early on the protocol, the trial design, and there was never any debate about those matters during the course of the trial. Importantly, it was as I said, a controlled trial, so there was a standard care, concurrent standard care group who received all stages of medical therapy but not craniectomy. Patients their allocation was concealed when they were randomized, so people didn't know which group they were being randomized into. That's important for trial quality. And most importantly, the outcomes were carefully measured at 6 months after the trauma in both groups. And those outcomes were measured by blinded assessors using structured questionnaires, usually by telephone calls. That was the primary way DECRA was set up. Now, what about the procedure itself? Well, we chose to use the Poland technique in the Poland trial as a base when setting DECRA up, and that was because although there were 50 or more case series in the literature of different types of craniectomy in severe TBI, none of those had controls, and nearly all of them reported better outcomes than expected. But Poland was the only one that had a it had a control group, which was a matched controls taken from a database. It wasn't randomized control, but they did have controls. And that trial suggested that looked at bifrontal decompressive craniectomy, the large procedure. They found that the ones that were done early, in that case within 48 hours of injury, had better outcomes. And it seemed that patients with diffuse refractory intracranial pressure done at that early phase was most likely to improve outcomes. So that was the base, and then the neurosurgeons modified the technique a little by extending it to a bifronto-temporoparietal craniectomy. You can see this is one patient from early in the trial where there's a large piece of bone removed, there's a lot of brain swelling, a lot of edema, a lot of brain swelling extending frontally through the craniectomy defect. and enabling decompression and enabling the ICP to be reduced. The surgical picture, looking down on an example brain, shows the technique that was standardized, which was bilateral cruciate incisions, Surgicel over the sagittal sinus to protect it. As I said, there were many neurosurgeons involved in this procedure, and in a number of countries, and there was uniform satisfaction that this was a reasonable way to do the craniectomy for the trial. Now, the next thing is what happened with the time course of the trial. Well, the trial ran for 8 years and screened in all the 15 centres ICUs nearly 3,500 patients with severe TBI. Many patients were excluded before the randomised group of 155 were identified and were split into the two groups. And it's important to look at that because the same is true today, that those potentially eligible with diffuse injury for craniectomy are a pretty small group. They're a localised, homogeneous group where we can probably learn things clearly scientifically from, but they're a small group. So a third of the patients with severe TBI were excluded because they had hematomas, they had mass lesion TBI. There were quite a number that were excluded because they were unsurvivable or had a poor prognosis. We didn't include children in this trial, although Jeffrey Rosenfeld, our lead neurosurgeon, had led a previous very small trial in children, a Taylor and Butt trial, which was done prior to this. But then, most importantly, I think, is that having done those trial exclusions, there were another third of patients, over 1,000, who were not included because their ICP was well controlled with this medical therapy, and that remains true today. And that's always important to note, I think. It wasn't. So the reality is that patients who have diffuse injury, who do have refractory, uncontrolled ICP, are a pretty small group. In this trial, it was about 5%. There are very few patients, although it was a difficult consent discussion, as you can imagine, and took a lot of time. There were very few patients that actually did decline consent. And after allocation to the two groups, the standard care group didn't receive surgery, but it did receive best medical care available, including when it was required, and it was quite often required, barbiturates and barbiturate coma. But then they were analysed within the groups that they were first allocated, so an intention to treat analysis, and there were no patients lost to follow-up, which was outstanding for any traumatic brain injury trial. Also, no patients withdrew consent at a later time point. What about the baseline characteristics of the trial patients? Well, we did these in the usual way at patient admission to hospital. And bear in mind, patients were not randomised at this time. They were not randomised until they became refractory, which was any time in the next 3 days after admission. But at admission to hospital, they were very well matched for age, and the patients were young, median age of only 24. The GCS motor scores were 3 in both groups, exactly the same. And the severe diffuse injury on CT scan, on Marshall scoring, was the case in 3/4 of patients in both groups. There was some imbalance in pupil reactivity at that time at admission to a hospital that was much discussed later, and I'll deal with a bit later when I look at the 12-month outcomes from the trial. But note also that because this was a 155-patient trial, there was always going to be some imbalance from side to side, and there was a counterbalance for patients who had hypoxic injury on top of their TBI. There were more of those in the standard care group, and there were more high-speed motor vehicle accidents in the standard care group too. So not everything was exactly the same, but overall we felt the balance was good, and so did the New England Journal. Now, so in summary then, the DECRA trial 10 years ago, 2011, was about diffuse injury patients. We didn't do that because we didn't care about mass lesion craniectomy. We just knew that it was going to complicate assessments and make it difficult to answer the key questions, so we focused on one disease. Other trials later have done other things. The patients were young, mean of 24 years of age. We enrolled patients within the first 3 days when ICP had become refractory, using a threshold for ICP that we used for all the other therapies in the ICU, the 20 millimetres of mercury at that time. It has gone up a little bit since then in the Brain Trauma Foundation guidelines, for just 15 minutes of repeated treatments. And if it was still refractory at that time, then patients could be consented and enrolled. It didn't include hypothermia, and it didn't include hypocarbia, but it was after sedation, paralysis, multiple hypertonics, multiple EVD drainage, which was recommended but not always in place. The aim was to do an effective procedure and prevent secondary brain injury if possible. And for ethical reasons, we permitted late rescue craniectomy to save a life if it was required. And that occurred, it was actually 18% of patients, but it did occur in the control group patients. And it had to, or it was impossible to do the trial and wouldn't have been ethical. Now, the first and most important, first of the key slides from the paper, this is what happened to intracranial pressure. Now, the red line is the point at which patients were randomized. So you can see the time period before that. If you look at the two groups, the blue dots are the craniectomy patients, the green dots are the standard care. And you can see that the ICPs in both groups are increasing in the hours prior to randomization to a range between 20 and 25. And then patients were randomized. If they were surgical group, they received a craniectomy. If they were medical, they may have received barbiturate coma. A couple of key things. Firstly, craniectomy was in fact very effective to control intracranial pressure. The control was sustained throughout the monitoring period afterwards, and it was clearly better than best medical care in terms of ICP control. But the next point I think that's worth noting is that in the medical care patients, there was also reasonable control of ICP. Not in every patient, but in the majority of patients, there was reasonable ICP control with the medical option. This then is the final 6-month outcome slide, as simplified to make it easy as possible to understand in the DECRA trial. The outcomes were measured as Glasgow Outcome Extended scale, and I've reduced it down to the 5 key groups here to make it clearest. On the right-hand side are patients who were independent in all activities of daily living, often called favourable outcomes. And the immediate thing to note is that the patients in the black bars, and they were the craniectomy patients, were clearly fewer in the independent recovery group than the grey bars, who are the best medical management group. Now, this finding was exactly opposite to what we had expected. It was shocking to us, and it stimulated a great deal of correspondence and anxiety and unhappiness amongst different groups. But these were the trial findings, unexpected but real. Now, looking at those who, on the left-hand side, who were dependent, so they were either dead or severely disabled, there are clearly more of those in the black bar group who had received craniectomy than in the medical therapy group. And there wasn't an obvious difference in mortality. So why would that be so? Well, one, we looked carefully for complications because we wanted to be sure. We did this all in centres that were very experienced, with experienced neurosurgeons, to minimise the risk of complications. We recorded hydrocephalus requiring a shunt as a key complication, and it did occur in 10% of our craniectomy patients, and it may have impacted long-term outcomes more than we had expected. There are many series of craniectomy patients and hydrocephalus needing shunting is very well described, often up to 40% in many of the published series. So that was no surprise. But we didn't find any other major complications of note in either of the groups. Particularly in the best medical care group, there were very, very few measured complications, which I think is probably a testament to the quality of the ICU therapy that these patients were getting across the 3 countries. The question of axonal stretch injury from the brain swelling outside the skull and stretching white matter was raised at the time. It hasn't been taken up really very well, but it's still a possibility, and I think still needs consideration going forward. So what were the key findings then again at 6 months? Earlier decompressive craniectomy, much better short-term outcomes, better intracranial pressure, shorter time in ICU, and that, as we expected, was because pressures were lower and sedation was turned off earlier, but no difference in mortality in this trial. Fewer independent outcomes, only 30% independent outcomes, fully independent at 6 months, versus nearly 50% in the standard care group. And it looked like more vegetative and severe disability outcomes, but that wasn't the primary result of the DECRA paper trial. But overall, not a great outcome for craniectomy in this trial, and that's why there was such a furor. So much so that I decided to leave the DECRA trial paper to stand on its own and to just see what would happen over time, to whether it stood up, and it has indeed become a classic paper now 10 years later, and the findings continue to be very important. So we then, we had always measured 12-month outcomes as a secondary endpoint from the DECRA trial, and so we put those together into another paper to report those. It was published early last year, and together with that, we wished to discuss and resolve some of the issues that had come up in relation to the primary New England Journal DECRA paper. We wanted to address in more carefully the question of was there truly baseline balance, or was the pupil imbalance, much discussed, important? And we did that in 2 ways. Firstly, by checking pupil reactivity at the true baseline point for the trial, which was prior to randomization. And secondly, measuring overall covariate balance using what we now have available, which is the impact probability calculation, which puts all the key covariates together into a single number. And then we could see for sure whether there was any important imbalance between those groups. We also wanted to look carefully at key subgroups: vegetative patients, poor outcome survivors, unfavorables, and also good survivors. And lastly, we wanted, it was raised, the crossover, the 18% of patients who had surgery late to save a life, whether that was important, whether it influenced outcomes. So when we look at the baseline table again, using pupil reactivity at the randomization point, on average 36 hours after admission for trauma, you can see that there is very little difference between the 2 groups. So what's happened is that with adequate resuscitation, pupil reactivity has stabilized and was in fact quite similar between the 2 patient groups, and wasn't a major cause of inequality between the 2 groups. Secondly, the impact probability of unfavourable outcome using the impact score to put them all together was exactly the same in both groups. It was 42% probability unfavourable in both groups, so telling us that although this was not a 5,000 patient trial, it was 155 patients, there was good balance and the randomization was effective. What about the 6-month and 12-month outcomes then? put together in this paper. So the top coloured bars are at 6 months, the bottom ones are at 12 months. And looking first at the bold or the solid red arrow, that's marking out the patients who have favourable outcomes on the right-hand side, the greens and blues, and the number of those patients has increased over time between 6 and 12 months, and in the standard care group. And in the dotted line in the surgical group, they have increased too, and the increase has been greater in the surgical patients between 6 and 12 months. So although at 12 months there are still more favourable outcomes in the standard care group, the difference is smaller. So perhaps because it's been the surgical group started from a lower base, those patients have improved quicker. Perhaps because complications have been improving over time. It's impossible to know, but the difference between the groups has narrowed. Then what about the difference between decompressive and craniectomy at 6 months? You can see it in the top bar. At 12 months, in the bottom bars, there is clearly a difference favouring standard care, but the difference is less than it was before. And then finally, what about vegetative outcomes and good outcomes? The ones we're perhaps most keen to get right in our care of patients. Well, vegetative outcomes seem to be clearly greater, the red bars in the craniectomy group, and the good outcomes, patients who are that we're really aiming to improve, seem to be clearly fewer in the craniectomy group at 12 months, as they were, maybe even more pronounced than they were at 6 months. Now, what about the numbers? Well, 12 months after injury, there were 59% unfavourable outcomes in the craniectomy group compared to 48% in the medical group, the standard care group. Nearly 60% increased, but at this time the difference was no longer significant. So it's a unfavourable trend at 12 months, whereas it's significant at 6 months. In relation to the other key subgroups, the vegetative survivors were 5 times greater in the craniectomy group, and that we saw as a matter of major concern going forward. That makes it very hard for neurosurgeons to choose which patients to operate on. That difference was significant at 12 months, and the good outcome survivors, 10% versus 26%, or only 1/3 as frequent in the craniectomy group, also significant at 12 months. So the last thing was, what about the crossover effect in the primary paper? So to look at that, we did an as-treated analysis by putting all the patients who had a craniectomy in one group and all those who didn't have a craniectomy in the other group, and comparing their outcomes at both 6 and 12 months. So at 6 months, there was still a doubling of unfavourable outcomes with DC surgery and with the as-treated analysis, and by 12 months it was a nearly doubling and a quite similar statistics. So the bottom line is that doing a as-treated analysis didn't change the overall findings of the trial. So in the randomised DECRA trial, 12 months after injury, severe diffuse TBI with early refractory ICP and early craniectomy, neurologic outcomes were not improved at 12 months. Vegetative survivors were increased, and good outcome survivors were fewer than the control group. So in now where we are now, and that was 2011. In 2021, there's still only 2 high-quality randomised trials in adults addressing this question. And by high quality, I mean a randomised trial with concealed allocation, with blinded outcome measurements involving high-quality intensive care, funded not by industry but by independent national funding agencies, and with decent patient numbers of over 100. That's the DECRA trial that we're discussing today, and the Rescue ICP trial that was published 5 years later, which was a bigger trial. And I'd put it to you that these two trials are different, and the differences have been much discussed, but their findings, I think, are complementary. So just a few points on rescue. It was the patients who were enrolled were mostly also diffuse injury. 20% were not, they were mass lesion patients, but the majority were also, like DECRA, diffuse injury. The patients were older, they were 24 years of age in DECRA, they were nearly 10 years older in rescue ICP, and that influences some of their outcome measurements considerably, I think. The ICP who's refractory in rescue ICP at a higher threshold, they chose 25 millimetres of mercury for a longer time period, at least an hour, and sometimes for many days. It was, once again, after failed first and second tier therapies, but hypothermia was an option and could be used and was used reasonably often, and I've mentioned the issues there. And fairly aggressive hyperventilation was an option as well, and was also quite often used in rescue. Whether those things influenced outcome is unknown. So they aimed for surgery later than the DECRA trial when ICP had been refractory for longer. So the underlying hypothesis was a little bit different. Rescue craniectomy was also, like in DECRA, was required for ethical reasons, and it occurred much more often, though, in rescue. It occurred in nearly 40% of control patients. What were the key findings? Well, in this different group of patients, they found decreased mortality, a very good thing, after craniectomy compared to control, 49, but their baseline mortality was very high, it's 49%. Remember, it was 18% or 19% in DECRA. They found no change in fully independent outcomes at 6 and 12 months, and they were only a quarter of patients. And they also, there were subgroup findings of increased vegetative and severe disability, which was a concern to many. So overall, less deaths, but definitely more severe disability outcomes. And there's a lot of discussion about the way favourable outcomes were defined in rescue. They chose to use independence at home only as being a favourable outcome. I'm not going to discuss that now, simply to say that it was a different definition point in the primary trial report. So what are the implications of these things? Well, in general, in severe diffuse TBI, in most patients, decompressive craniectomy is not effective to improve long-term independent outcomes, probably in part due to complications, although we don't know that for sure. Another implication is that these findings were all in high-income units and countries where all the facilities were available. ICP was always measured, and comprehensive long-term intensive care was available, and that's not true in many lower and middle-income countries. We think it's likely that long-term outcomes in both groups are likely to be worse in lower and middle-income countries, even though decompressive craniectomy, we know, is widely used in many of those countries today, in part due to its feasibility. There is an implication, and I'm sure it's true, that there are selected patients who have perhaps more localized lesions in less important areas, perhaps younger patients with better outcome predictions. So selected patients are quite likely to benefit, but it's a hard thing to do, and a collaborative decision-making point to decide which patients might possibly benefit from craniectomy today. Last, then, I think it's worthwhile to put the two randomized trials together in a meta-analysis. They're not exactly the same, but few trials in a meta-analysis are exactly the same, to see what the overall results were when you put them together. And those findings are here in this slide. So in relation to fully independent GOSEs 5 to 8 outcomes, they are not different between the two groups. So put together, both the trials suggest that there's no improvement, but there's also no major difference in independent outcomes if you put them together. But there are two problems, and they are that there is a 4 times, this is with the 2 trials together, a 4 times incidence of vegetative outcomes, which nobody wishes to have, and there is a nearly 2 times increase, both significant, both of these things, in severe disability outcomes, which nobody wants to have either. So what are these implications for young neurosurgeons' practice? Well, I think it's clear that in diffuse injury, different to mass lesions, that secondary craniectomy should be reserved as a last option, lifesaver, for selected patients who we are pretty sure have a chance of a reasonable functional outcome. Not earlier, because it didn't benefit, but in DECRA. But so after the ICPs consistently over higher thresholds of at least 25 millimeters of mercury, after barbiturates have failed, because barbiturates were the primary additional therapeutic option in DECRA, and that group in DECRA had better outcomes. And only, I think, when the patient and injury factors suggest there's good potential for independent outcomes, young patients, no secondary insults, probably frontal contusions, but without brainstem injury. And importantly, when the healthcare system in the country that you're in it does have the capacity for substantial long-term rehabilitation, which is not true in all countries, but for a number of years needed. What about other implications? Well, in severe TBI patients, although severe ICP elevations can definitely kill people, can cause coning and can cause death, and can be saved by craniectomy. What about less severe but still refractory intracranial pressure? And it seems more likely now, after these trials, that severe refractory ICP is mainly an association of brain injury severity rather than an ongoing cause of secondary injury. And this is, I think this likelihood has caused a lot of rethinking amongst specialists globally. And this way, why decompressive craniectomy may save some lives, but at the cost of severe disability survivors. Many for the medical therapies that are used for patients in ICU, it's very important going forward to have excellent attention to detail for those therapies. They're detailed, they're listed here. I'm not going to go through them, but they are complex to get right, and it's an absolute requirement if that that method is going to be engaged rather than craniectomy surgery. And last point about translation of research into clinical practice. Translation usually takes 7 to 10 years. Many papers have shown that. However, we have done a retrospective 5-centre study in Australia over 2 years, done 2 to 4 years after the DECRA trial was published, of severe TBI patients, and found that only 2% of patients who were eligible for the DECRA trial who in these 4 years later were receiving one, and that was compared to 4% and then 8% in increasing rates prior to the DECRA trial publication. So that suggested to us that in one country where the trial was led and done, that there had been translation into practice within 4 years after the trial publication, so quicker than one might have expected. So this is the Alfred Trauma Centre in Melbourne, where the trial was led and where I work. And I'd like to pay tribute once again to the many people there and all the other sites and neurosurgeons and intensivists in 3 countries who contributed to this trial. Thank you.
Well, thank you so much, Dr. Cooper. We really appreciate that presentation. Does anybody in the audience, the participants, have any questions? You can raise your hands or type it in the chat.
While we are waiting for that, hi, Dr. Cooper. I'm Faith Robertson, one of the members of the Young Neurosurgeons Committee. First off, thank you for making the time for this. I think that this is the first in a series of what we want to do for webinars for landmark papers in the field, and this allows us to put these online even afterwards to allow people to have access to these conversations. So, particularly those who had some of these key trials that have started to change management, I just wanted to thank you for that. Two questions. One, when designing a trial that's large, it's a tremendous amount of effort. And then, as you mentioned, you're starting to analyze a lot of the data. And sometimes we think or see then things we maybe would have done differently. So I'm just curious, if you were to redesign the study, knowing what you know now, is there anything that you would do differently for the DECRA study?
That's a great question. I think the answer is no. Back in 2002, we put together, we've got a very collaborative group of intensivists and neurosurgeons in our part of the world, linked through the clinical trials group. We spent a lot of time together discussing what we felt was the optimal way to do a very difficult trial like this. We knew all the key points that we had to include to maximise the quality, and I've mentioned those. And we were, I guess the major thing to consider is whether we really intervened at the best time point, and that's been discussed quite a bit. I don't have any problems with the surgery that was used in DECRA. As I said, there were many neurosurgeons who were completely comfortable with that, both in design and grant stage and study stage. It was only afterwards, when the results were not what everybody wanted, that people started raising questions about that. So I don't have any problems with that. The time point of intervening, I'm really glad actually that we intervened when we did, when best medical therapies had become refractory before barbiturates, because I think if we hadn't done that, we would never have been able to move forward with the idea about how problematic really is refractory ICP in relation to secondary brain injury. So I was completely happy, actually. There was a huge amount of work that went in, and at that time I think that was the best way to do the trial.
My second question you actually touched upon. So I don't know if it's, there are different styles of practice in different parts of the world, and one of the main ways I think we do a lot of our hemicraniectomies, at least in the U.S., whether it's an MCA stroke, a malignant cerebral edema, or TBI, is more the unilateral temporotemporal parietal cranium, really getting to the floor of the temporal fossa. And one of the critiques that's come up about the DECRA trial was truly decompressing the middle fossa and getting low enough in the temporal area to prevent herniation. It sounds like you've also heard some of those comments. I'm just curious if you could elaborate more on thoughts to that argument.
Yeah, look, I'm not going to be able to help you that much, because the surgical technique was decided by Jeffrey Roosevelt and Peter Riley and the other Australian neurosurgeons. The literature was very clear at that point that bifrontal craniectomy with a large bone opening was likely to be the best way to safely reduce pressure at that time, 10 and 15 years ago. I think that's still true now, but there'll be differences about that. I'm very suspicious that the reason that unilateral craniectomy is used often is because of mass lesions, and that mass lesions, hematomas, are being evacuated at the same time, and that's why the craniectomy is really being done on that side. And then the follow-up as to whether the bone's left out and whether the craniectomy is enlarged or not, but then follows on from the fact that that hematomas were being removed. So I think the key thing to note is these patients did not have hematomas. They might have had small contusions, but they didn't have big ones, more than 5 centimetres, and they didn't need to have hematomas evacuated. As I said before, that narrows the group down to a smaller group. You could argue that it's therefore not generalisable to other groups of patients, and in part that's true. But it also does give a clear result, which teaches us a lot about refractory ICP control, I think. And I guess the other thing to say is that the criticisms that have been raised about technique, nearly the ones I've seen, nearly all suggest that we could have had better ICP control by doing it a different way. Now, you've said that in one form, but there's other things that have been said. And that, to me, is not the point, because we did get excellent ICP control throughout the patients who had craniectomy with the technique that was used. That wasn't the problem. There was excellent control of pressure, but the problem is that pressure control didn't lead to better outcomes. So if we were to use a technique that got even better pressure control by the technique adjustment, it seems highly unlikely that would have any effect at all, I think, on long-term outcomes, if you know what I mean.
Dr. Cooper, I don't know if you can see the question that popped up, but we have one of the participants who wrote that in their trauma bay in Nigeria, they don't routinely measure ICP, which is something you had mentioned as is a limiting factor of the DECRA trial. But they make the decision to decompress using clinical and radiologic assessments, and they seem to have fair outcomes on that. And they were just curious what your take on that is, and how perhaps they could apply DECRA without the continuous ICP monitoring, or if any of the findings of your clinical findings that you utilize, such as you talked for a while on the pupil findings, could apply to places that are unable to do ICP monitors.
So several comments, I think. It's a really good point, and I did mention it during the talk, that there are many countries in the world that don't have the capacity to do long periods in intensive care and all the supports that are available in higher income countries. And what in the world do people do in that situation? That wasn't studied in DECRA, as you know. But I think the implications there are, firstly, that very early craniectomy to save a life when there are clear signs of herniation, coning, those patients would receive immediate craniectomy in Australia, New Zealand, the US, the same as Nigeria. And so I don't think those patients are at all controversial, assuming that they had a chance of a long-term reasonable outcome. It's more the later patients, and what's the place of decompressive craniectomy in a country that can't do periods of intensive care, that basically can't do a medical option alternative for a period of time. And we don't really know the answer to that. I think the most important thing is that practitioners in those countries are cautious in the use of craniectomy, because clearly it needs to be done. It can be done to save lives, but it will create vegetative and long-term severe disability outcomes in many people. And that is probably more true in low middle income countries than it is in the higher ones. So there is a big proviso, and it makes it very hard to decide. But the answer to the question, it doesn't come out of the DECRA trial. It doesn't. All that trial does is to teach us that although craniectomy can save lives in selected people, it's not the answer in many patients, and it increases long-term problems in many patients. And that will be true in Nigeria too. I guess the last point to make is that I did say at the beginning, this is 20 years ago now, there were nearly 50 case series in the literature of all pretty much reporting improved outcome from whatever their technique was in many different places, or nearly always one centre rather than multi, but never having any controls. So without controls, you really don't know. And those case series led us astray for a long time, I think. So a lot more work needs to be done in lower middle income countries. I'm very cognizant of that, and it's hard, but a lot of work needs to be done. And the answer, I'm sure, is not simply doing craniectomies on everybody and living with the consequences.
Sure. Cool. Do we have any other questions from the audience? Anyone who wants to chat or raise their hand? Well, if that's the case, Dr. Cooper, we really appreciate your time and that wonderful presentation. I think this is a very high impact presentation and outcomes that certainly we utilize every day in our practice.
Thank you. Thank you very much, Maggie. Thank you.
All right, well, we'll wrap this up, and we will work on getting this posted to our YNF online YouTube case series. And then also stay tuned to see the next in our series of landmark papers in neurosurgery, which will be coming up very soon. Thanks, everybody, and have a good evening or daytime.